Bismillahirrahmanirrahim. The topic for today's presentation is malaria. I am Dr. Ayesha Amin, PGR of FCPS Community Medicine at Institute of Public Health, and I'll be presenting this under the kind supervision of my professor and teacher, Professor Dr. Saira Afzal, who is the Dean of IPH Lahore. So, quote for the day is: "The life of this world is only the enjoyment of deception." The learning outline for today's presentation is Introduction, Epidemiological Determinants, Clinical Features and Complications of Malaria, Prevention and Treatment, Burden of Disease, Malarial Programs of WHO in Pakistan, Recent Advances in Malaria, and multiple choice questions. Learning outcome. By the end of this presentation, the participants would be able to understand the epidemiological determinants of malaria, clinical features of malaria, national and global burden of malaria and its prevention strategies, and to be able to answer the multiple choice questions. Introduction. So, malaria is a life threatening infectious disease which is caused by a Plasmodium parasite and is transmitted to humans through the bite of infected female Anopheles mosquito. Malaria literally means mala, which means bad, and area means air, is a protozoal infection. It remains one of the most significant global public health challenge, particularly affecting tropical and subtropical regions. Despite being preventable and treatable, malaria continues to cause substantial morbidity and mortality, especially among young children, pregnant women, and population with limited access to health care. Coming to the epidemiological triad of the malaria agent, malaria is a mosquito borne febrile disease which is caused by a malarial parasite, a disease caused by the members of the protozoan genus Plasmodium. Parasite affects the human liver and red blood cells. Humans are infected with Plasmodium protozoa when bitten by an infected female Anopheles mosquito vector. Symptoms may appear within weeks to months or even years. There are four types of Plasmodium, that is Plasmodium falciparum, vivax, ovale, and malari. The Plasmodium falciparum is most virulent and life-threatening species. It causes high parasitemia due to the invasion of red blood cell of all ages. It causes severe malaria, which is known as cerebral malaria, severe anemia and renal failure, leading to the blackwater disease, no dominant liver stage, so it does not cause relapse. It is common in Africa and South Asia, including Pakistan. Plasmodium vivax. It is most widely distributed species, causing relapse malaria due to the dormant liver forms, that is hypnozoid. It invades young RBCs. Usually, the disease is mild, but it contributes significantly to the disease burden. Plasmodium malari, it causes chronic low-grade infection. It invades older RBCs and it is associated with nephrotic syndrome. There is no relapse but can persist for years. Plasmodium ovale, similar to the Plasmodium vivax, is causes relapse due to the hypnozoite stage. It is rare but mainly in West Africa. Plasmodium knowlesi, it is zoonotic malaria in which monkey act as a reservoir. Rapid 24-hour erythrocytic cycle which can cause severe disease, and it is seen mainly in Southeast Asia. The host. Humans are the definite host for malaria. The susceptible groups are children under 5 years of age, pregnant women, and non immune travelers and migrants. If there is a lack of immunity or partial immunity, pregnancy, again, malnutrition, genetic factors, that is sickle cell traits, they offer partial protection against malaria, and socioeconomic status and limited access to healthcare. The environmental factors: warm climate, that is optimal temperature 20 to 30 degrees centigrades, high humidity, stagnant water are the breeding sites, ponds, irrigation channels, poor housing and sanitation, rainy season and monsoon and post flood, and agricultural practices and deforestation. Vector. The vector for malaria is a biological vector, and the parasite completes parts of its life cycle inside the mosquito and part of its life cycle inside the human RBCs. The infective stage is sporozoite stage, which is present in the mosquito's salivary glands. The breeding sites are the clean, stagnant water, pond, rice fields, irrigation channels, water collections after rain. Biting habit: it mostly bite at night, dawn to dusk, indoor and outdoor biting, and depending upon the species, resting behaviors. Some species rest indoors, that are endophilic, others rest outdoor, exophilic. They are important for vector control strategies. And vector for malaria in Pakistan: Anopheles culicifasces for rural areas and Anopheles stephensi for urban areas. The incubation period, the reservoir for infection is human reservoir. The Plasmodium falciparum has incubation period of 9 to 14 days, while Vivax has incubation period of 8 to 17 days. For whale, it is 16 to 18 days, and for cotton malaria, it is 18 to 40 days. Types of malaria, there is benign tertian malaria. The causative agent is the Plasmodium vivax and Plasmodium ovale also. The fever pattern is the fever spikes at every 48 hours. Severity, it is usually mild but may cause complications. Relapse, it present due to the dormant liver forms, that is hypnozoid, and it's common in Southeast Asia including Pakistan. The quatern malaria is caused by Plasmodium malariae. The fever pattern, the fever spikes at every 72 hours and it is usually mild. Relapse is not present in quatern malaria, and the chronicity of infection, that it may persist for years. While the malignant malaria, it is caused by Plasmodium falciparum, the pattern of the fever is irregular and it is severe and life-threatening kind of malaria. The relapse is not present in case of malignant malaria, and the chronicity does not persist for years and may show recrudescence if treatment is inadequate. Mode of transmission, the malaria is caused by mosquito bites. The other modes of transmission can be from mother to unborn child and through blood transfusion by sharing needles, in which is used to inject drugs. The life cycle, malarial parasites undergoes an asexual life cycle in human, liver and RBCs, and a sexual cycle in mosquito, with sporozoid infecting humans and gametocytes infecting the mosquito. This diagram is showing the life cycle of the Anopheles mosquito. As we can see in the liver of human, the sporo at this stage of sporozoid, this when mosquito bite the human, it inject the sporozoids. So the sporozoid, they move to the liver where they form the merozoite, and then these merozoids enters into the RBCs, and in the RBCs they cause rupture of the RBCs and the merozoites are released in the blood. And the rest of the cycle of the female Anopheles mosquito is completed outside the human body. The clinical features of the malaria is cough, headache, fatigue, nausea, vomiting, respiratory problem, the fever which is associated with chills, and there are muscle aches. There are certain symptoms such as there can be abdominal pain, joint pain, bloody urine, that is dark color urine, seizure, or yellow discoloration of eyes and skin, which is jaundice. And that is because due to the hemolysis of RBCs. The complications of malaria is cerebral malaria, breathing problems, organ failure, anemia, and low blood sugar. Diagnosis, the clinical diagnosis, and there is a laboratory diagnosis as well. In clinical diagnosis, the history of fever with chills and rigors, residence in or travel to endemic areas, and the associated features of anemia, splenomegaly, headache, and vomiting. While the laboratory diagnosis is basically the peripheral blood smear is the gold standard test, which is used to diagnose malaria, in which the thick films and thick smears are prepared. The thick smears, they detect the parasite, and the thin smear, they identify the species of the Plasmodium. Then there are rapid diagnostic tests also. Also, there is polymerase chain reaction, and then there are supportory laboratory findings in which CBCs and renal test and liver function test are performed. This diagram is showing the upper part of the diagram is showing the thin smear, and the lower part of the diagram is showing the thick smear. So the a thick smear, it identify the Plasmodium parasite, and in the thin smear, we can identify the exact species of the Plasmodium which is causing the malaria. The management of malaria, the mainstay of the treatments are the anti-malarial drug therapy according to the species and severity. And then there are artemisinin-based combination therapy for Plasmodium falciparum. There is a chloroquine and artemisinin combination therapy for Plasmodium vivax. There is primaquine, which is used for mainly for the relapse cases in case of Plasmodium vivax and ovale malaria. Then there is supportive care in which antipyretics, fluids, and electrolytes, and blood transmission in case of severe anemia is done. The management of hypoglycemia, there is hospitalization is needed in case of severe cases, and we need to monitor the patient for complications and treatment response. Coming to the prevention of malaria, the primary prevention is health education and community awareness. Vector control, which is basically to use the insecticide treated bed nest and indoor residual spraying. Environmental management, elimination of the stagnant water, improved drainage and sanitation, and personal protective measures such as mosquito repellents, wear light colored long sleeved shirts and trousers, and we should sleep under a bed net, use insect repellents that contain DEET or IR3535, or get rid of the stagnant water from places where the mosquito breeds, such as old containers, flower pots, used tires, and use screen for mosquito nets in windows and doors. Chemoprophylaxis is another option for prevention. It is the use of anti-malarial drugs to prevent the malarial infection, especially in travelers to endemic areas or high-risk population. The indication for chemoprophylaxis is travelers who are traveling to malaria endemic regions, and pregnant women in high risk areas, and immunocompromised individual. The common drugs which are used in chemoprophylaxis is the chloroquine, which is used against Plasmodium falciparum malaria, and it is mainly used in pregnancy. It is given weekly. Start 1 to 2 weeks before travel and continue 4 weeks after leaving. Then mefloquine, Plasmodium falciparum. Again, it is used against Plasmodium falciparum, and it is given weekly. It should be given 2 weeks before the travel and then continue for 4 weeks. Then there is also the option of doxycycline, which should be started 1 to 2 days before and continue for 4 weeks after, and it should be given daily. But the doxycycline, it is contraindicated in pregnancy in children under 8 years of age. And then there is an other drug which is known as atovaquone proguanil, that is Malaron. Should be given daily, and it should be started 1 to 2 days before and continue 7 days after. It is well tolerated, but it is expensive. The specific protection, that is vaccination. WHO updated its recommendation for malaria vaccine in October 2023. Malaria vaccine, primarily RTSS, that is Mosquirisk, and R21 matrix Ms, are safe and effective tool recommended by the WHO to fight Plasmodium falciparum malaria, significantly reducing severe cases and death in children in endemic area. The malaria vaccine should be provided in a schedule of 4 days doses in children from around 5 months of age. At fifth dose, given 1 year after the dose 4, it may be considered in areas where there is significant malaria risk remaining in children a year after receiving dose 4. The secondary prevention, again, comprises the early diagnosis and prompt treatment, which is done by a thick and thin film and rapid diagnostic test in case of emergency and outbreaks. Then there is prompt and effective treatment, which we have already discussed. And then there is active and passive case detection and surveillance. The tertiary prevention focuses on management of the severe malaria and complication, hospitalization and intensive care, rehabilitation of patients with neurological or renal sequelae, and prevention of disability and death. The surveillance. Improved surveillance of malaria cases and death help ministries to help determine which areas or population groups are most affected and enable countries to monitor changing disease patterns. Strong malaria surveillance system also help countries design effective health intervention and evaluate the impact of malaria. The surveillance is done as in pre-eradication area, eradication area, and through vector indices. In the pre-eradication area, the malaria magnitude of malaria is determined based on the diagnosed cases. The classical malarimetric measures in pre-eradication area is spleen rate, average enlarged spleen, and parasite index. The spleen rate, it is defined as the percent of children between 2 and 10 years of age showing enlargement of spleen. The average enlarged spleen is a further refinement of the spleen rate, devoting the average size of the enlarged spleen. It is used full malarimetric index. And then there is a parasite rate, percentage of children between 2 and 10 years of age showing malarial parasite in their blood film. In the eradication area, the parameters which are used for a measurement of malaria are following, that is annual parasite incidence, annual blood examination rate, annual falciparum incidence, slide positivity rate, and slide falciparum rate. The annual parasite incidence is defined as the confirmed cases during 1 year divided by the population under surveillance into 1,000. The annual blood examination rate is defined as the number of slide examined divided by the population into 100 population. Slide positivity rate is the percent of slide found positive of malarial parasite irrespective of the type of species. And slide falciparum rate is the percent of slide which are positive for Plasmodium falciparum parasite. The vector indices used in surveillance is a malaria survey is not complete unless it includes the investigation relating to the insect vectors. Some of the important vector indices are human blood index, porozoite index, mosquito density, man biting rate, and inoculation rate. Coming to the epidemiology of malaria, the global burden. Globally in 2024, there were an estimated 282 million malaria cases and 610,000 malarial deaths in 80 countries. The WHO African region carries a disproportionately high share of the global malaria burden. In 2024, the WHO African region was home to 95% of the malarial cases, that is 265 million, and 95% of the malarial death. Children under 5 accounted for about 75% of all death in the region. In the right side of the figure, at the right side of the slide, you can see a figure which is showing the number of malarial death by age around the globe, and we can say that the major chunk of these disease mortality is children under 5 years of age. The blue portion signifies the number of deaths which have been taken place in children under 5 years of age. The national burden of malaria. Malaria is an endemic in Pakistan. Between January and August 2022, over 3.5 million suspected cases of malaria were reported in Pakistan, compared with the 2.6 million reported over the course of 2021. Over 170,000 cases were laboratory confirmed, of which 77% are due to Plasmodium vivax and 23% are due to Plasmodium falciparum, which is associated with the most severe and fatal cases. A rapid upsurge in cases was observed in Balochistan and Sindh province after the devastating flood in mid-June 2022, together accounting for 78% of all confirmed cases. Reports from 62 high-burden districts indicate that the additional 210 10715 cases were reported in September 2022, compared to 178 657 cases reported in the same district in August 2022. This map is showing the number of cases of new malarial cases per 100,000 in Pakistan, and we can see that there were around 18 new cases of malaria per 100,000 of the people in 2023. The death rate from malaria. This map is showing the number of death from malaria in 2021 in Pakistan. And we can see that there were around 3.8 deaths per 100,000 people in 2021 from malaria in Pakistan. So what is the WHO response against malaria? The WHO has global technical strategy for malaria 2016-2013, which was updated in 2021, and it provides a technical framework for all malaria endemic countries. The strategy sets ambitious but achievable goal in targets, including reducing malarial case incidence by at least 90% by 2030, reducing malaria mortality rate by at least 90% by 2030, and eliminating malaria in at least 35 countries by 2030, and preventing a resurgence of malaria in all countries that are malaria free. The core principles are all countries can accelerate effort towards elimination through combination of intervention tailored to local context. Country ownership and leadership with involvement and participation of communities are essential to accelerating the progress through a multi-sectoral approach. Improved surveillance, monitoring, and evaluation, as well as the stratification by malaria disease burden, are required to optimize the implementation of malarial interventions. Equity in access to services, especially for the most vulnerable and hard to reach population, is essential, and innovation in tools and implementation approaches which enable countries to maximize their progress along the path of elimination. So this is the global technical strategy for malaria 2016-2030, and it has three pillars. The pillar one is ensure universal access to malaria prevention, diagnosis, and treatment. The second pillar is accelerate effort towards elimination and attainment of malaria free status. And the pillar three is transform malaria surveillance into a core intervention. The supporting element one is harnessing innovation and expanding research, and supporting element two is strengthening the enabling environment. These are the goals and the targets of the global technical strategy of malaria. And it states that the eliminate malaria from countries in which malaria was transmitted in 2015, and the target is to take the number to at least 35 countries, and prevent re-establishment of malaria in countries that are malaria free. So the target is to prevent the re-establishment by 2030. Malaria control program in Pakistan. The malaria control has always been a priority in Pakistan. The National Malaria Control Program was started back in 1950. In 1961, the Malaria Control Program was converted to the Malaria Eradication Program under the auspices of WHO with the financial and the technical support from WHO, UNICEF, and USAID. In 1977, the Malaria Control Program was integrated into the health services as a part of the communicable disease control in Punjab province. The program forges consensus among key actors in malaria control, harmonize action, and mobilize resources to fight malaria in endemic areas. It aims to reduce the malaria associated morbidity and mortality by keeping malaria under effective control. The main objectives of this malaria control program is to ensure and sustain the provision of quality assured early diagnosis and prompt treatment services to greater than 80% of at-risk population by 2030 to ensure and sustain the coverage of multiple prevention intervention, that is inside residual spraying, use of insecticide treated nets and other innovation vector control tools and technologies to 100% in the target high risk population, to increase the community awareness up to 80% on the benefits by early diagnosis and prompt treatment and malaria prevention measure using health promotion, advocacy, and behavioral change communication intervention by 2020, to enhance technical and managerial capacity in planning, implementation, and management and meal, that is monitoring, evaluation, accountability, and learning of malaria prevention and control, to ensure availability of quality assured strategic information, that is epidemiological, entomological, and operational for informed decision making, functional, passive, and active case-based weekly surveillance system in low-risk district, and to ensure provision of malaria prevention, treatment, and control services in humanitarian crisis, emergencies, and cross-border situations. Malaria elimination. The malaria elimination is defined as the interruption of the local transmission of a specified malarial parasite species in a defined geographical area as a result of deliberate activities. The continued measures to prevent re-establishment of transmission are required. The countries that have achieved at least 3 consecutive years of zero indigenous cases of malaria are eligible to apply for the WHO certification for malaria elimination. As of January 2025, a total of 45 countries and one territory have been certified as malaria-free by WHO. This map is showing the number of countries who have achieved the malaria-free status by WHO. And we can say that the Southeast Asian countries like Sri Lanka, Maldives, and the countries like Uzbekistan, Tajikistan, Kyrgyzstan, they all have achieved the status of malaria-free. While unfortunately, Pakistan has not yet achieved the status of malaria-free country. The recent updates in malaria. So this is taken from the WHO side. The WHO welcomes the recent approval by the Australian Therapeutic Good Administration of a single dose tefenoquine for the prevention of Plasmodium vivax malaria among children of age 2 to 15. As a single dose, tefenoquine is expected to support patient adherence to treatment, and the current standard of care requires 17 to 14-day course of medication. While there is an other medication which is known as ganaplacide lumefantrine, it is a combination and it is currently in the phase 3 clinical trial. Here it is mentioned it is in phase 2 clinical trial, but at some other site it was mentioned that it is also is now in phase 3 clinical trial. Is the first non-artemisinin combination therapy and could be an asset to fight against the emerging drug resistance malaria in Africa. The ganaplacide lumefantrine is a combination and is the first new class of anti-malarial treatment in decades. Phase 3 trials in Africa, they showed a high cure rate of 97.4%, outperforming the standard treatment. A key feature of this combination is its ability to kill the drug resistance parasite and block disease transmission to mosquito, potentially making it a significant tool in the fight against resistant strain. Regularity approvals could see it that it would be available in the market to as soon as 2027. Coming to the multiple choice question. The first MCQ is a traveler to a malaria endemic area asked for chemoprophylaxis. Which of the following drug is safe and effective for short-term prophylaxis? A is chloroquine only, B atovaquone proguanil, 3 primaquine, D artesunate, E doxycycline.
C. D.
The drugs which are used for chemoprophylaxis are basically chloroquine, atovaquone, and doxycycline. So for the short time and effective prophylaxis, the best option is atovaquone and proguanil. However, it is expensive. In severe malaria, a patient develops cerebral malaria. This is an example of primary prevention failure. B. Mild disease. C. Complication during tertiary prevention. D. Secondary prevention and vector control failure only.
Charlie.
Yes, the right answer is C. Complication requiring tertiary prevention. A 5-year-old child present with the repeated fever every 72 hours. Peripheral smear shows trophozoite of a quatern malarial parasite. Which species is most likely responsible? A. Vivax. B. Falciparum. C. Malaria. D. Ovale. E. Knowlesi.
B. Falciparum.
The quatern malarial parasite is basically the Plasmodium malaria. It causes the quatern malaria, while the falciparum is cause malignant malaria. The fourth MCQ is during post-monsoon surveillance in a village, a 3-year-old child present with the fever, chills, and anemia. Peripheral smear shows ring forms. The public health officer suspect Plasmodium falciparum. What is the most urgent action? A. Start chloroquine only. B. Admit and start intravenous artesunate. Give paracetamol only. Observe and repeat smear in 24 hours. E. Start primaquine.
Alpha.
The right answer is B, as the patient has is a young patient and has developed severe anemia. So the right option will be to admit the patient and start intravenous artesunate. A traveler to Southeast Asia seeks malarial prophylaxis. She is pregnant and will stay for 2 weeks. Which drug is safe and recommended? A. Chloroquine. B. Doxycycline. C. Atavaquine. Proguanil. D. Primaquine. E. Artesunate.
Delta. C.
The right option is chloroquine. For a pregnant female, and for chemoprophylaxis, the right option is chloroquine. Which of the following is the most effective intervention to reduce malaria burden at the community level? A. Hospital-based treatment only. B. Mass distribution of insecticide nets and vector control. C. Annual vaccination of adults. D. Chemotherapy for all symptomatic cases only. E. Blood transfusion for severe cases. The right answer is B. Mass distribution of insecticide-treated nets and vector control. The seventh MCQ in 2021, WHO has recommended the first ever vaccine against malaria. Which of the following age group of people can get the dose of vaccine who are living in the malarial epidemic regions? A. Children 5 months to 10 years, 15 years and older. C. 60 years and older. D. Infants only. E. Adults only.
B.
No, the right answer is E. The
A.
children as young as 5 months to 10 years of age can take the malarial vaccine if they are living in the malarial endemic regions. The eighth MCQ as health worker teaches village to remove stagnant water and cover water container. This is an example of A. Vector control and health education. B. Early diagnosis. C. Tertiary prevention. D. Case management. E. Hospitalization.
A.
Yes, A is the right answer. The ninth MCQ is during a malaria outbreak, a public health officer wants to identify all the infected individual proactively, even those without symptom. This is an example of A. Primary prevention. B. Secondary prevention. C. Tertiary prevention. D. Quaternary prevention. E. Vector control.
A.
Mm,
B.
no, the right answer is B. The last MCQ is a National Malaria Control Program evaluates malaria incidence, mortality, and ITN coverage annually. This is an example of A. Vector control. B. Chemoprophylaxis. C. Case management. D. Health education. E. Surveillance and monitoring.
E.
Yes, E is the right answer. This is the key to MCQs. These are the references. This is the YouTube channel of the Institute of Public Health where the recording of this presentation will be uploaded. And thank you for your patient listening.
Thank you very much, Dr. Ayesha, and everyone who has attended today's learning session, especially Dr. Amna Zaman, Dr. Kamran Ejaz, Dr. Temia, and Dr. Amna Khalid. It is a wonderful session, and Dr. Ayesha, if you please stop the recording so that I can give both constructive feedback as well as the effective feedback.